Welcome to the 8th episode of PD Exchange, the Peritoneal Dialysis podcast, where we discuss the latest and the best of peritoneal dialysis literature. I'm your host, Dr. Nikhil Shah, a nephrologist at the University of Alberta, Edmonton, Canada, and with me is my co-host, Dr. Jeff Perl, a nephrologist at St. Michael's Hospital, University of Toronto, Canada. Dr. Perl is also the editor-in-chief of the journal Peritoneal Dialysis International. Jeff and I would like to thank all our listeners for supporting this novel initiative and providing feedback. For a podcast on a niche subject, we are happy to share with our listeners that we have more than 1,000 plays now and were recently informed by FeedPost that we made it to the top 10 dialysis podcasts on the internet. You are in for a treat today, as our guests are none other than Dr. Edwina Brown and Dr. Yeoung Jee Cho, along with Dr. Melissa Cheetham, who will be joining us shortly. Dr. Brown, as most of our listeners possibly know, is consultant nephrologist at the Imperial College Renal Centre and the Hammersmith Hospital in London, UK. And her clinical interests are peritoneal dialysis and dialysis care of the elderly. And she is also the current ISPD President. Dr. Cho is a consultant nephrologist at the Princess Alexandra Hospital in Brisbane, Australia. She is a PD researcher and a clinical trialist and the current Deputy Editor-in-Chief of PD International. And Dr. Cheetham is a nephrologist at the Sunshine Coast University Hospital in Australia, and she is a clinical researcher with an interest in home-based dialysis.
Thanks, Nikhil. And on behalf of all of our listeners and myself, I want to thank you for all the hard work you're putting into the podcast. And I hope that all of you are enjoying it on your commutes to work, and hope that it's helping make PDI a more relevant journal. So just to square things out here, I don't know if you guys remember last time we talked about the guidelines on exit site and catheter-related infections, and by fluke had an all-male podcast. So this week, we have an all-female series of participants today. So I hope that we've rounded things from that perspective. And the topic today is a real hot-button topic. It's really hard to go anywhere in the peritoneal dialysis community to a meeting or to a series of lectures or to open a journal and not hear some mention or discussion about incremental peritoneal dialysis. And maybe, Edwina, I'll ask you, why do you think incremental dialysis has sort of taken off as of recently? What do you think some of the factors that are responsible for us talking about it so much these days and the renewed interest in it?
I think it's because we're lowering the burden for the patient, the person doing dialysis. It's a break from standard factory delivered dialysis that you tend to get in hemodialysis units. And when I give talks on the topic, I call it incremental or personalized PD. It's a way of adapting the prescription to the needs of the individual. You know, when I talk to audiences and say, well, I give days off as one of the ways of doing incremental PD. When I started doing this, there used to be gasps. And then I would say, well, hands up, those of you who want to work 7 days a week. Nobody put their hands up. So I said, well, if you don't want to work 7 days a week, why are we making our patients do their PD 7 days a week? So I think we're making it a more attractive treatment. And there's absolutely no doubt that we're getting more people starting on PD when they realize it's not such a big burden as they thought it was going to be.
Yeah, and what do you think about, do you think that the relaxation or de-emphasis of small solute targets has also played a role, that we don't have to, particularly dialyze to a specific KT over V urea or target, that's also allowed us to be more flexible in our approach to initial prescription?
Yeah, well, yes and no. I mean, we started doing incremental PD several years ago, really, long before the new ISPD clinical prescribing recommendations. It was partly led by the nurses who said, why don't we do it? Because they had noticed that many of our patients actually were doing incremental PD without us knowing it. In other words, they skipped days, they skipped exchanges, and this is a way of actually giving people permission to do what they were doing anyway. So now people actually ask us if they want an extra day off. I always say yes, and unless they're really completely anuric and overloaded.
And Yeoung Jee, I just wanted to highlight that a lot of the research now in this issue of PDI, we have two really interesting studies, both from down under, from Australia, New Zealand. One, which was a secondary analysis of the BALANCE trial, and the other one using ANS data registry. Maybe you can help us just very briefly just go over what the studies were intended to do and what the findings were with regards to incremental PD.
As Edwina mentioned, there has been an increasing interest and desire to implement incremental PD. There's also been at the same time some reluctance and fear about what that means in terms of patient safety and outcome, because it is a somewhat unknown entity in countries like in Australia. So we have sort of decided to look at our data to examine how to best inform. And these are the two studies that were done quite differently, trying to answer that question. First of all, was the study that was the secondary analysis of the BALANCE trial. Many of the audience may be familiar with this trial, which was published more than a decade ago, which was a randomized controlled trial of incident peritoneal dialysis patients examining the utility of biocompatible solutions defined as neutral pH, low GDP against conventional PD solutions, in examining residual kidney function as a primary outcome. So obviously this was not a study examining incremental versus full dose. So we decided to look at this from that angle. In fact, an idea was suggested by a key PD researcher in the field. So looking at it, we divide into two groups. And as you can imagine, the patients who were allocated to incremental was significantly lower at 45 and a full dose of 109. So patients who were prescribed with lower dose PD were chosen by lower dose by their PD clinicians for one reason or the other. And we looked at their residual kidney function at baseline up to 24 months in follow-up period. And what we noticed was, unsurprisingly, that their residual kidney function was slightly higher in incremental group, which showed a similar level of slope of decline in residual kidney function over time compared to the full dose. So in the end, what we noticed was that the mean residual kidney function defined by the arithmetic mean of urinary clearance, so creatinine and urea, were higher in the incremental group nominally. However, the slope of decline was similar between the two groups over the 24-month period. Obviously, this is not a study that was randomized to examine this very much in question, but what we were able to ascertain was that the trend in residual kidney function did not seem to differ between the two groups. Then we decided to look at the data at a registry level to see what the uptake or the penetration of incremental PD is like in the region by extracting the data from the ANS data registry led by Dr. Melissa Cheetham. This was a study expanding over 10 years a period in ANS data registry. And what we've been able to identify is a prescription of lower dose PD defined as less than 42 liters of PD fluid per week was about 2.7% among patients who are newly starting peritoneal dialysis as their first journey of kidney replacement therapy. Over 10 years or so, there was been a significant increase in uptake of this to 11.1% by 2017. Mind you, ANS data registry is quite limited in the sense that we only collect data annually at the end of each calendar year, which means that we don't have understanding of what patients initially started with their journey. We only know at the 31st of December, December of each year's prescribing. But whilst understanding that limitation, there's definitely been a trend of increase, which seems to predate the high prescribing quality guideline that was released by the ISPD. So there's no denying that, as Edwina pointed out, that there is a desire to prescribe this more. What was notable, however, was that more than 67% of the patients actually were receiving this lower dose PD for more than 1 year. Everybody sort of transitioned to full dose by the time the 1 year mark was reached. As to what triggered that is a bit uncertain. And there appeared to be some differences in prescribing pattern. So it wasn't something that was uniformly taken up by every unit, but it was more prevalent in certain units than others. And there appeared to be some differences with regards to demographic characteristics of people who are more likely to be prescribed incremental versus not. For example, patients of the First Nations and those of the middle age group who are likely to be working, even though you think that those people might be more likely to be doing incremental, they were actually less likely to be the users of the uptake, which may relate to the patient bias or which may be related to prescriber bias. It is a bit uncertain. At the end of the day, registry data, as you know, is hypothesis generating, and it does not it does not result in a definitive evidence. But what we are able to appreciate is that there is a pattern of difference in how we are approaching incremental PD. And certainly there needs to be some more evidence to help us inform and reassure so we can, we can make an evidence-informed shared decision-making with our patients.
I think that those studies are, obviously there's limitations with observational data. There's certainly confounding by indication. Perhaps the patients that were more likely to use a lower dose dialysis were of a different body size, or perhaps had different levels of residual kidney function. And I know that you guys, as robustly as possible, adjusted as best you could. And so I think that these studies, from my perspective, really give a green light as to the safety. There may be some benefits from clinical, but there certainly weren't any observable harms with incremental PD. And I think for those of you who are sort of scared of under-dialyzing patients, looks like in the first year, the prescriptions could be maintained. And of course, residual kidney function is really important. And of course, I just want your thoughts, Yeoung Jee. I mean, the definitions of incremental in this study, probably if we were going to look at this prospectively, probably wouldn't be the ones we would particularly use. And I totally understand, the limitations of looking at an observational data set and trying to develop a definition. What do you think about how we should be thinking about incremental PD if we're going to study it further in terms of what we should be thinking about the definition of it should be? And then there's no standard definition, but this is just getting your feedback on it.
I think it depends on where you're prescribing from. I think that does have a big impact because there is no denying that how much PD we prescribe can be very varying. For example, in Asian countries where people are of smaller body habitus, it is not infrequent that people are considered on full therapy despite being on 3 exchanges of CAPD a day, for example. In countries like in Australia, we would consider the full dose to be 4 exchanges of CAPD and for APD to be with no dry abdomen and having 24/7 PD. So currently the standard definition of incremental will be anything less than that, okay? But I guess if you are to do a further study to examine incremental PD, in reality, I think that it would need to be a less in terms of starting point and gradually up titrating. And it's interesting that you mentioned this because I've just held a consumer workshop last week to try to better understand what patients feel as to what they value more. Is it less exchange numbers? Is it less in volume? Is it about having a day off a week or maybe more? And I'm just waiting. I've provided them with the data and we are having a follow-up meeting to further discuss this because there has been some discussion and preference that perhaps for some people it's a day off that's most important. Others it may be different. To me, it would depend on what my life needs are and what would make my life easier in many shapes. And then what suits one person might not suit all.
I couldn't agree with you more. And I think incremental PD is really something that we have to contextualize in the context of what is being prescribed in that particular region, because as you said, volumes are different. And also how we start should really, I think to Edwina's point, be a personalized decision. And we really, there's different ways to start a prescription. We have to think about what might maximize the patient's experience of PD and transition to PD and be flexible in terms of our definition of incremental PD. And I just want to point out that in the same issue, we're really lucky that Corinne Minera and Robert Carlson, who's a patient, put together an editorial called Incremental PD. I'm lucky to only be doing 2 exchanges. And I encourage you all to read that because it really gives the patient perspective. And Edwina, just some comments for you about definitions of incremental PD and how you look at it.
I think it's anything less than full dose. And what we start people on will depend slightly on residual kidney function, slightly on their volume status, on their age, symptoms, and also their anxiety about starting dialysis. So, for example, I had a patient in the clinic just today who is exceedingly anxious about starting dialysis. And his GFR is going down because he keeps cancelling his PD catheter insertion dates. And he's now got a GFR of 5. But I've told him that we would start him on just 2 exchanges on an assisted CAPD program and let him realize what dialysis is all about. And then gradually, so even 2 exchanges will keep him safe. And then just gradually introduce the idea that he needs to do a 3rd exchange and train him how to do it himself. His goal is to get back to Jamaica. So he's going to have to learn how to do PD himself. And that's why he has chosen PD and not hemo.
And you mentioned a really great point. In Toronto, for example, we have a very multicultural population, and a lot of our patients have family back in various countries where only CAPD is supported. So, I think we sometimes oversell APD and undersell CAPD. But for those patients, I tell them, if they want to go back to that country to visit family and friends, they will only be able to do CAPD. And one thing that I've realized is that, doing 1 or 2 exchanges of CAPD really levels the work, if you think about it, between APD and CAPD. We present CAPD as 4 bags a day, breakfast, lunch, dinner, bedtime. And of course, when you say APD, you're going to connect it once, disconnect it once, you're going to sleep, and the magic's going to happen. Of course, it sounds so much better from a quality of life and lifestyle perspective. But if we prescribe incremental if we prescribe CAPD with an incremental approach, I found that it does level the sort of burden playing field between CAPD and APD. And actually, being able to start CAPD, there's no machine, there's no alarms, there's better sleep, there's less anxiety. And guess what? They can do CAPD if they have to down the road, if they're traveling or if they're going to be under a different circumstance. So I think incremental, at least in my program, has really allowed us to do more CAPD.
One of the decisions to consider incremental peritoneal dialysis also depends on the caregiver, because it may not only the patient who's involved in the PD, but if the caregiver is working and you try incremental prescription, you can have a patient on PD rather than transitioning them to hemodialysis or starting them on hemodialysis. So I think that concept about caregiver burnout, you can help with that as well with incremental PD.
Yeah, and then one other question, again, Yeoung Jee knows this is coming because this is a little bit of controversy. We're going to spice things up. Edwina, myself, and RT Dude and Bruce, we all wrote an editorial based on these 2 articles in ANSDATA. And it really fundamentally raised a question. And speaking to people, there's really these 2 differing camps. On the one hand, people are, this is wonderful. We want to do anything to reduce burden. Observational studies would suggest there's no harm. It may be benefit, including the ones published in this issue. We can go off to the races. We can feel confident to continue to prescribe incremental PD. We don't need any further evidence generation. On the other side, one may say, the data is observational. A lot of the studies are poor quality, single center, haven't really prospectively designed a study with real, thought and consideration to look at these really important critical endpoints. And all of us, I think, would argue that the most important reason to do this is to improve the patient experience of PD. We definitely need more studies in this realm and particularly more robust studies. So I'm going to get both of your views on this. Edwina, I'm going to get your view, and I'm going to ask Yeoung Jee for your position, which I feel may be different, but we'll see how this plays out here. Edwina, what are your thoughts about this sort of controversy? Do we need more study for it to be standard of care in our PD programs or not?
I think if you're actually observing your patients and asking them how they are and looking at their biochemistry, prescribing incremental PD does not do harm. And if you advise your patients that they're going to have to increase their dialysis so they're educated in advance that they're going to have to increase. And mostly, once people get symptomatic, they want to increase their PD anyway. So I think doing a randomized study would be really difficult, just like any other randomized study we try to do in PD or in dialysis. Because if you told people, we think it's equally safe to start on 5 days a week, 2 exchanges, or even 6 days a week, or whatever regime you're going to start them on, or you can do the full, prescription, who's going to join the study? I mean, it'd be like the PD versus hemo study that the Dutch tried to do. You wouldn't be able to recruit into it. So I think the data has to be observational. From the observational studies that have come out so far and from people's personal experience, there is no signal of harm.
Okay. And Yeoung Jee, let's get your perspective on this.
Before I say anything, I am a very pro-incremental PD physician. Okay, that's my disclosure. But that does not change my view that I think that trial is needed, just because I not infrequently find myself advocating it against the resistance, because there are definitely people out there who feel concerned about the safety, and they're also concerned about difficulties of trying to convince our patients to increment PD at a time when it's needed, because there's no evidence to inform that decision. And because of that challenges that people face, they actually don't want to do incremental PD from the get start, because they worry about ability to escalate dialysis as clinical needs arise. So I do think evidence is really needed to do some shared decision making. And PD, I think, is a wonderful therapy for people who live particularly in a remote and regional town, not very close to where dialysis units are from hemodialysis. And when you think about the need of incremental monitoring and needing to gauge the needs, clinical needs as they develop, having evidence to inform us to have that discussion with the patients and rightly timing in terms of reviews and escalating will help us to improve patient outcome. When you look at the data, it's often the very ones who are living in regional areas who are missing out on incremental PD for the very reason the physicians feel anxious about not able to monitor and support these patients. So if we don't have further evidence to really guide us, it's really hard to implement it broad across for equitable access to therapy that we believe is good for our patients. In my unit, I fully disclose that not everybody start dialysis incremental because nurses feel very uncomfortable about incremental PD, because they have had a lot of friction with the patients, with our patients, about needing to increase therapy at a time when it's needed. So although we like to think that patients really want it, there's no doubt patients want it, but is it really appropriate to continue at the rate we're going? I think I say that there is more evidence that's needed to help us guide in that decision-making process. And I think we can't do it with the randomized controlled trial, because observational studies have their limitation, because often when you look at the observational data, they are retrospective in their nature, the registry data. It is really, you cannot minimize the residual confounding despite extensive multivariable model adjustment at the end of the day.
And I'm just going to give you an analogy here, and then I'll sort of give you my opinion to level things out here. Balance, right? Balance essentially the Balance study, which the study that we're talking about was based on as a secondary analysis, looked at the impact of low GDP neutral pH solutions on preservation of residual kidney function. As part of a randomized controlled trial, if I'm not mistaken, there may have been a signal towards a lower risk of peritonitis in the low GDP neutral pH group. When the data was looked at in Ann's data, if I'm not mistaken, there was a higher risk of peritonitis with the low GDP neutral pH solutions. So sometimes it's interesting how observational data and randomized control trial data do give us different perspectives on the same intervention. So it just highlights the limitations and caveats we have to apply with all the observational data. So I think in general, we're supportive of moving forward with randomized control trials in PD. And you mentioned a really important point. Edwina needs not any convincing, nor I think her unit would ever participate in such a randomized control trial. But I do think that I think the main impetus is because you think people without this data are being deprived of the opportunity of incremental PD. And I think that that's important, and it contextualizes that such a study may only be done in certain areas where there is resistance and there is hesitation. So I think it really, again, just like incremental PD definition is contextualized by geography, so too is probably the impetus and feasibility of doing a randomized control trial. I can probably say in my program, my nurses are quite the opposite. They're all focused on reducing the burden of therapy and improving the transition to PD. So we very often start with 1 or 2 CAPD exchanges, and definitely with APD advocate for a night off. I will say that a night off often becomes 2, and a second night off often becomes 3. And again, that's the challenge with expectation setting and making sure that we're balancing safety against patient experience. And it'll be interesting to get those insights in a future randomized control trial.
So I have a question for all 3 of you. We've always been doing incremental peritoneal dialysis in our programs in some way or the other, whether it is a dry day or a day off or whatever. Have you noticed change towards starting people earlier with an earlier GFR just to accommodate this? And then the second part of it is, what makes you decide if a patient is on incremental dialysis to advance the dialysis prescription?
So let's unpack the first one. Edwina, what do you think? Has incremental led to a shift in earlier starts on PD?
Definitely not. No, is the answer to that one.
And Yeoung Jee, what do you think?
I also believe not. It has not changed my practice in terms of when we start dialysis.
Yeah, and I'll say also not. I mean, we know from the IDEAL study, which was as well a study that was done in your part of the world, Yeoung Jee, led by Carol Pollack, that starting dialysis at a lower level of GFR was associated with similar outcomes to starting dialysis early, and there was no benefit to starting dialysis early. So I don't think incremental is sort of a license to prescribe dialysis earlier. Having said that, in the IDEAL group, in the patients that were randomized to late start, a lot of patients in whom PD was their intended modality ended up starting urgently on hemodialysis. So we definitely need to plan early, no matter what therapy we start, and definitely start when it's appropriate, and I don't think that there's a role to start early. I think people have interpreted the no benefit to start early to start super late when people are uremic and nauseous and vomiting and significantly hyperkalemic. So I don't start early, but I also don't think in the later start group we should be starting super late, because I also think there's a risk there. But I don't think that it has necessarily changed my view on things.
Jeff, before you unpack the second question, I'd like to welcome Melissa. Hi, Melissa. I hope everything worked out okay.
Hello, nice to see you all.
Nice to see you, Melissa.
Sorry, I'm a little late in joining.
That's okay.
Oh, no worries. So Nikhil was just asking a second question, and we'll ask Edwina, how do you monitor and what are some of the triggers to increase the PD prescription when one starts with an incremental approach?
Well, it's first, are they losing residual kidney function? And looking just at the plasma creatinine, is that going up? If the creatinine's going up and they're actually doing their dialysis, then that's very suggestive. So that would make me say to the patient, it looks as though, your kidney function is it was going down before you started on dialysis. It's going to continue going down. So I fire a warning shot, as it were, that we're coming to a stage where they may have to increase. Obviously, if they start getting, if they start saying they're more tired or their appetite's down or they're getting fluid overload, then that's another trigger. And often we will ask them to bring in a clearance test, or we'll look at their latest clearance test. So it's, I would never change a prescription just because of the result of a clearance test. It's part of the jigsaw. And then sometimes the patients are quite honest and say, I'm beginning to feel like I did before I started on dialysis. And often these conversations just happen with the nurses in between clinic. I mean, we see patients every 2 months, alternating between nurse and medical, and sometimes all of this is just sorted out by the nurses in between medical visits. So it's a combination of symptoms, biochemistry, and clearance tests, and firing warning shots so that patients know that they're going to have to increase their dialysis, and then we'll give them a choice. So say they're doing 2 exchanges 6 days a week. We'll say, well, you could go up to 2 7 days a week. You can introduce a 3rd exchange, maybe, every other day or something like that. Or, or you can start thinking about APD. And so we discuss with them how they want to increase their dialysis.
What do you think some of the triggers are that you would employ in addition to what Edwina said? Let's just say we were designing a study. What would be some key important points to think about when considering when we need to increase the PD prescription?
I share similar trigger points with Edwina. I don't ever move on biochemistry alone. It needs to be a clinically meaningful clinical changes, largely around a fluid. Also with regards to biochemical changes, particularly things like potassium. As you know, PD is really good at managing potassium. And if it starts rising, you'll be thinking, oh, there must be something else going on, unless it's a mango season or something like that in Australia, where patients really go quite hard. So I definitely clinical indicators, if there's been any hospitalization, for example, with fluid gains or any other reasons, that would also be a very important clinical indicator to increase. And hopefully we don't reach that point. But I think there's regular reviews, as Edwina has mentioned. We also see our patients every 2 months or so, and that's an important opportunity to assess. And I do take very particular notice of their weight and their fluid in particular, because it's usually a good indicator of how things are going. Yeah. And before increasing, I also do ask people, because as Jeff, you mentioned earlier, sometimes when it's meant to be missing 1 day, it can extend into 2 days. And you do need to have a very frank discussion about, are you doing PD as prescribed? Are you doing incremental PD as we discussed? Or are you doing ultra incremental PD?
There may be a lot of ultra incremental PD. And so I think you guys all hit, I think, really important points. Measurement of residual kidney function, again, evaluating symptoms, not just focusing on biochemistry, and also setting expectations that the prescription might have to increase, and also offering different ways to increase prescriptions. One thing, Melissa, we had Yeoung Jee did a great job summarizing the study you were involved in, which was using the ANS data registry to look at incremental PD on outcomes. One of the interesting findings also, if I'm not mistaken, was a lower risk of peritonitis. Previous study in Asia, I believe in China, that looked at 3 versus 4 exchanges and also found a nominally lower risk of peritonitis. What do you think is driving that? Do you actually think that doing less exchanges might actually lower the risk of touch contamination events? Did you see any difference in terms of gram-positive, the typical skin bugs we think about in terms of peritonitis risk being a particular group that was associated with a reduced risk? Any thoughts on that finding, which I found really interesting?
Yeah, there's a couple of potential reasons why we might see an outcome like that. So as you say, less risk of touch contamination just by virtue of doing fewer exchanges is one possibility. Reduced glucose exposure through, again, either fewer exchanges or lesser volume that they're using overall is another possibility. I think ultimately we don't really know, and even in our study, although we did see the reduced risk of peritonitis, when we looked at transplant and death as competing events, we didn't actually see a significant difference there. And through the previous studies that have looked at peritonitis in incremental versus standard PD, again, the outcomes are, it's overall not really clear, I think, what the effect on peritonitis is. It's made more difficult again by the fact that the way each study defines their incremental and their standard group is different. All these different studies use different definitions, whether it might be the number of exchanges per day, even in the number of exchanges per day, some studies might use 3 as being incremental, 3 exchanges a day is incremental, and others will use 3 as being standard. Other studies will incorporate days off into their definition, or dry days, and others don't. So although there is a potential reduced risk of peritonitis, I think we probably still need a bit more data to really know what the effect is there.
Yeah, no, that's a really important point.
And then I think one thing to note is that to do a trial looking at peritonitis as an outcome of interest, you need thousands of events to be powered to ascertain the difference. Okay, so none of these studies are really powered to adequately, ask these questions and answer this question. And these are observational studies, and there could be myriad of other factors which could have influence other than intervention alone at the end of the day. And patients who are allocated or chosen to receive incremental, there are reasons associated with that very proactive choice that's been made in this uncontrolled manner of allocation. So I think we have to always interpret these data with a caution.
Have you noticed a center effect at uptake of incremental dialysis and outcomes?
Yes, I mean, it's going to depend on the enthusiasm of the people who run the unit. I mean, I'm fortunate. I work with 2 other nephrologists. I'm not going to say they both do what I tell them to do, because I think that they would object to that. I mean, we and the nurses all sing from the same hymn sheet, as it were. We're all firm believers in incremental. So virtually all our patients, unless they're completely anuric and uremic at the start of PD, will go on a reduced regime, even if it's just for a few weeks, as a step, starting dialysis. So instead of going wham into full dose, it's a small climb. So it just makes the journey slightly more acceptable. But then you can have another unit where hardly anybody uses it.
Yeah, I do think, Nikhil, undoubtedly, there's different perceptions about it, and the prescriber does influence its uptake. Melissa, I know, one of the really important parts of your study was you did show an overall increased uptake in lower volume PD over time. Did you guys see that was heavily concentrated in some centers, where if you looked at the proportion of new starts in some centers using that, it was much higher than other centers? And any, without naming specific centers, of course, any center characteristics that seem to track with using more?
Yeah, we definitely saw a wide range in the uptake of incremental or low volume PD. So while we found that, the median proportion of incident patients starting with an incremental prescription was 3.2%, the interquartile range was from 0 to 27%.
We need to send Edwina to the 0 unit, by the way.
So there are some units that are using it, almost routinely, I would say, for their patients who they feel that it's suitable. And there are some units who are not using incremental prescriptions at all, and all their patients are entering PD on a standard prescription. And when we looked at the centres, there is quite a number of centres that aren't using any at all. In terms of what characteristics of centres that seem to use it versus those that don't, it would seem that perhaps experience with PD might be the main factor. So when we looked at the predictors of incremental PD use, we found that centres that used less APD and less icodextrin were less likely to use incremental PD, and those that used more low GDP solutions were more likely. So those are perhaps markers, of centres that use PD more often, and that maybe have more a process in place that It means that these things are considered for each patient, so that perhaps they go through their checklist, or that all patients straight away, the thought is, can they do APD? Can they have a low GDP solution? Can they be started on icodextrin from the get-go? Can we start with an incremental prescription?
Yeah, I mean, that makes sense. And you know, I can just say from my experience speaking to people and speaking to nurses, in general, I think the people, and Edwina, this comes back to Edwina's initial point that incremental PD is personalized dialysis. The whole spirit of incremental PD is to reduce burden and improve quality of life. And I think the prescribers who really fundamentally believe in that vary the PD prescription according to the needs and considerations of the patient. So, you know, rather than one unit, everybody goes home on the same prescription, no matter what. I think giving some thought into each unique individual needs and quality of life considerations, and it may even just be a marker of units that are varying out the PD prescription depending upon the unique needs of the patients, and that just happens to be more incremental PD.
Can I add that it drives our finance people mad, because every patient has to be, the invoices have to be checked against the prescriptions, so they have to go line by line through the invoices that it's correct for each patient.
But so, aren't you saving them tons of money?
Yeah, of course we are, yes.
So they got their work cut out for them then.
And I think that point about incremental PD being personalized prescription is really important, because while in our study, we could only use the weekly exchange volume to define incremental versus standard just based on the data that was available. What would be really interesting to know is how different centres are delivering incremental. So, and how that suits the patient's needs, their quality of life, their wishes. So does having days off improve their quality of life, or do they prefer to have a dry day every day, but to allow them to say be more active, but they're happy to do it every day at night? Or do they just want to do fewer exchanges? Do they just want to have less fluid in general? So these are the things that we don't really know, but would be important, because if we're saying that incremental PD has the possibility of improving patients' quality of life, what does each patient want, and how can we alter the prescription to suit that?
That sums up it so adequately, because I just saw a patient who wants to golf every day. He doesn't want fluid in his belly at that time. And you know what? He's 75 plus, and he's like, no, I'm happy with the way things are. I'm doing what I want. So I'm happy with my prescription. Don't change it. He's very, very particular.
I think we've discussed most things. I think we need to remember that we are not the people on dialysis. And however many people we have looked after gives us some ideas, but we're still not having to do it. So we really have to listen to the person, try and make dialysis as acceptable as possible. Even if we feel that the dose at the start is not appropriate or not large enough, start with them a low dose. None of us would want to go from normality to having to be on a full-blown dialysis prescription. You know, on Tuesday you have a normal day, and Wednesday you're doing full dialysis. That would be shattering. So do it stepwise, and make use of the residual kidney function.
I don't think there is a better point to stop. We are grateful for all of you to join today and participate in this fantastic discussion. I think this should be a norm, and I think we should just support more centers who are hesitant in initiating this. We should be available for discussions, and I think we should be able to do that and reach out to more people with our podcast. And that's a wrap, folks. Links to the paper are in the episode details. And please reach out for comments, suggestions, and questions. Our Twitter handles and email addresses are in the episode details as well. Hope you enjoyed this exchange. This is Jeff and Nikhil signing off until the next PD Exchange. Take care.